Hi, my name is Colin Gershon. I'm one of the nurse practitioners in the emergency department here at Oregon Health and Science University. I'm going to talk today about a systematic review we conducted on the diagnostic yield of non-invasive cardiac monitoring, so that's Holters, external loop recorders, various novel patches, etc., placed in the emergency department setting. I want to start by thanking my co-authors and colleagues, Dr. Andrew Moore, librarian Andrew Hamilton, and our statistician Amber Lynn. We have no conflicts of interest. As all of you know, syncope is an extremely common diagnosis in the emergency department, and it's also challenging because ED providers often have to discharge patients without a definitive etiology of the syncopal event. For decades, EDs have been referring syncope patients to the cardiology clinic to pick up 48-hour Holter monitors or loop recorders. But as Cook and colleagues showed in 2018, more than half of patients discharged from the ED with a diagnosis of syncope never picked up a mobile telemetry device. This might have been due to practical or logistical barriers, health insurance issues, etc. The evaluation of syncope has changed in some EDs in the past few years with the advent of 14-day mobile telemetry devices. These devices, which are just a little bit bigger than a credit card, are placed on the patient's chest just before discharge. So more high-risk syncope patients getting a mobile telemetry device, starting the recording immediately rather than in 1 or 2 days, and keeping the telemetry going for a longer period of time may improve the diagnostic yield of the syncope workup. However, to date, there are no meta-analyses or systematic reviews of studies examining the diagnostic yield of mobile telemetry started on patients while they're still in the emergency department. So our objective was to examine the diagnostic yield of non-invasive cardiac monitoring initiated among patients discharged from the ED with a diagnosis of syncope. We searched Medline, Cochrane, Scopus, Google Scholar, first in November 2019 and then again in May 2020. We used mesh terms including syncope, near syncope, palpitations, ED visits, and the use of non-invasive cardiac monitoring devices, as well as device brand names. We found 4 manuscripts in the published literature. These first 2 are by Reed and colleagues in the United Kingdom. The first study looked at the diagnostic yield of a 14-day patch, and the second study looked at the 90-day yield of a patient-triggered loop recorder. Schreiber and colleagues studied a 14-day patch in 3 EDs in the United States, and Davison and colleagues studied a 24-hour Holter in a single ED in England. This slide shows the average diagnostic yield among all devices. So 7.35% of patients had a run of VTAC, 3.88% had any kind of block, 13.35% had SVT, 5.4% had AFib, and no patients had VFib. When comparing the diagnostic yield across different devices, the 14-day patch had by far the highest yield, detecting a dysrhythmia in nearly 45% of patients. The 24-hour Holter found a dysrhythmia in about 25% of patients, and the 90-day patient-triggered device found a dysrhythmia in less than 10% of patients. In conclusion, we found a small set of heterogeneous studies. These showed significant variability in the diagnostic yield between telemetry devices. The 14-day device was found to have the highest yield. However, the studies didn't quantify the novelty of the diagnosis. So, for example, devices detected SVT in 13% of patients, but we don't know in what percent of patients this was a new diagnosis. Similarly, the current studies don't evaluate how often a detected dysrhythmia led to an intervention or an improved outcome. This illustrates the need for an RCT that quantifies the diagnostic yield of a 14-day telemetry device, with the primary outcome of percent of new dysrhythmias and the percent in whom a detected dysrhythmia leads to a new intervention or improved outcome. Finally, the study should evaluate how ED-based telemetry compares to usual care, which is outpatient-placed mobile telemetry. Thank you for your attention, and I welcome your thoughts.